Every now and then you'll speak to somebody who'll tell you a story about cataract surgery in remote settings or in developing countries, and they'll give you a story where everything went terribly wrong. You'll have the story where 60 people were operated and 40 of them went blind. Or you'll have a story of the man who had his cataract done and everything was great, and then he went to the river and he washed his face and an infection got in and he lost the eye. Or somebody rubbed their eye and everything went disastrously wrong. Are they true stories? And if they are, is it the fault of the patient or is it the fault of the medical team? And that's what we're going to discuss today in Beyond 2020. Today we're going to look at endophthalmitis, the most feared complication of cataract surgery or any intraocular surgery. It does occur everywhere in the world, and incident rates in a good hospital seem to sort of be somewhere around about 0.03, and the rate can go up to 0.5%, and possibly on cataract camps, in remote settings, that might be even higher. So today we're going to look at what can be done to alleviate or to reduce that incidence of endophthalmitis to zero if we can. And there are some practical steps that you can take when you're organizing surgical camps in remote settings that reduce that incidence right down. The first thing to get right out of the way is that it's nearly always the fault of the surgeon. Maybe not the surgeon, but the team that put the surgeon in that position. It's nearly always something we put in the eye that causes endophthalmitis. It's not, or it's very rarely, the man who goes to the river and washes his face and he got this terrible infection as a result of that. I suppose it could happen, but generally if you've closed the eye well, you've done a good tunnel, you've done a good closure to your wound. If you have to, you've put sutures in, you put the conjunctiva back over the wound, you patch the eye for the night. It's difficult for something to get into the eye following surgery. It's much more likely that if there is an infection, it's something that you put in the eye with one of your instruments that wasn't clean. It's nearly always us that causes it, and that is the main thing. So if you understand that, then you can start to work on what it is that you need to do, what it is that you need to be better at to prevent endophthalmitis from occurring. One of the things that we found out very early on in our work in Bolivia was that you can't trust the sterilizing equipment in most rural hospitals. It doesn't get to temperature. It might say that it does, and also, and sadly, you can't always trust all of the staff to sterilize things properly. We had one incident one year where I handed a tray of equipment to be sterilized to the proper staff in a hospital whose only job was to sterilize things, and they returned it to me half an hour later, like freezing cold. And I couldn't believe that this had been sterilized. And I think what happened is one person put it in the sterilizer but didn't turn it on because their shift had changed. They were going off, and the new person came in and thought, this must have been done the night before. And there were no checks. There was no tape used on the actual trays. But even the tape can be misleading, because unless you remove it every single time, you can be guided by tape on a set of instruments from a previous operation. So it's not necessarily the right thing. So we made the decision to buy our own sterilizer and to go antiquated, to go for heat with pressure. Now that limits us a lot in terms of certain instruments won't go through. So, you know, some of our expensive anterior vitrectors, for example, you just show them the sterilizer and they melt. But everything metal will. And as long as it's an instrument that can withstand heat, it is by far the best thing to use in a remote setting. And maybe I'll do a talk on individual sterilizing of instruments on another occasion. But be in control, that's the point I'm trying to make. Make sure that you are 100% confident that your instruments are sterile before you start an operation, before you stick them in somebody's eye. The second thing is you're going to be working in an operating room that may not be used as an operating room ever before. We will often go to a town, we'll pick the best room, the one that seems the cleanest and or the most workable, and then we will turn that into an operating theatre within a week. Largely you start off with a room that is nothing like clean, and you need to focus on getting the air clean. Most places in the world are probably very good at cleaning floors, but in ophthalmology we want the air to be clean. So you need to look at you know, what could contaminate the air. You need to look at the type of ceiling in the room that you've got. If it's a wooden ceiling with you know, panels that have been joined together, well, it's at those joins that dust and all sorts of things, bat guano, insect feces, all sorts of things can fall from a wooden or a plastic ceiling. So be careful of those rooms. I much prefer a painted ceiling or a tiled ceiling, but painted probably is the preference. And I would look very carefully at light fittings and air conditioning units. So when we've just come back from Magdalena, the first thing that we did when we chose the room we were going to operate on was just remove all of the long tube lights and replace them with just a simple bulb, no lampshade, just a bulb hanging from the ceiling. It's the cleanest thing by far. The air conditioning units, think again about how much dust is in those units that has accumulated over the years, and whether you should even be using them. You know, effectively an air conditioning unit sucks germs from outside and dust and all sorts of antigens and pumps them into the air of your operating room. So it needs to be clean if you're going to use it at all. And we work in temperatures of 40, 41 degrees, so we use air conditioning, but you need to have it cleaned really, really well before. You might want to put some mosquito screens or some insect screens on the outside so you don't kind of pump flies into your operating theatre. That has happened on occasions before. And you need to get it really, really clean, and ideally position your operating table quite well away from it, so that if anything does get pumped into the air, that hopefully it drops somewhere different to where you're operating. One tip that is very useful after you've washed your ceilings, washed your walls, and taken everything out of the operating theatre, cleaned everything outside, and you start putting it back in, the first night before you operate, put a piece of black paper on the operating table and put a piece of white paper on the operating table, and then just leave it all night. And in the morning, anything that's fallen from the ceiling that is white will probably show up on the black paper, and anything that is darker will probably show up on the white paper. And if you think that there's too much dust in the air, then you need to think about cleaning it again, or think about changing to a different location. And only start your operating when you're confident that your patient lying on his back with his eye open facing, or her eye open facing straight upwards, isn't going to get a bit of dust or a bit of rust or some foreign body that just gently floats down into the eyes. The next area to think about is reusing instruments. What can you safely clean and reuse? and what you shouldn't really try and use. And our view is very much one of, if it has a lumen, then don't reuse it. So things like Rycroft's, I wouldn't use them again. Any cannula really, or cystotomes, if you're doing subtenons, don't reuse those. I know that there's a cost to them. I know that if you use them several times, that there's a saving and you might be a small charity, but be really, really careful with anything in a lumen. Anything else, like pincers, scissors, I think you can generally clean those quite well. We tend to use alcohol and water. Then we dry everything by hand and air dry, and then we put it into our sterilizer, and we need to reach a temperature of 125 degrees for 3 minutes at 2 atmospheres, and that scientifically has been shown to kill everything that could possibly exist at surface level of our planet, and it should be enough to make sure that you're not putting a bacteria or a virus or anything else into the eye that's going to give you a problem later on. At the end of each of our intraocular procedures, we put 0.2 of 1 ml of dexamethasone into the eye, and in the same syringe we would also mix 0.2 of apricam or cefroxime, and we also put that in to the eye. So the volume of the anterior chamber is somewhere around about 0.4 of an ml, and effectively we fill the whole thing with dex and apricam. Once we have completely sealed the eye and we check that the pressure is good, then we will put 1 drop of iodine onto the eye, and we will then add a small amount of chloramphenicol in an ointment to the eye, and we'll cover the eye for the night, and the patient will go home and we'll see them the following day to start them on dexamethasone. And we tend to use either chloramphenicol or tobramycin as 2 standard, fairly broad antibiotics, which we'll give to our patients for a month following their operations. After our surgeons have gone, you need somebody to stay for about a week. Most endophthalmitis will present within 72 hours, but you need to consider that your patient might not notice and might not be able to get to you straight away. So if they live a day away by boat, or it takes them some time to get back to you, they might notice their vision is down, and maybe they're feeling something, but they might not come to you. They might just assume that is normal, or by the time they realize something is definitely wrong, it might be 2 or 3 days before they can get back to you. So I think you need to have a presence for at least a week following all of your operations. Now, you could train the local doctor to do that for you, but if you're going to need to inject, then it needs to be somebody who's trained to do that, and to try and talk a local doctor through doing injections into the vitreous without anybody there, I don't think that's a good idea at all. And you really need to have somebody who is there or who's able to get there very, very quickly to treat endophthalmitis. It's also interesting whether or not to do both eyes for your bilaterally blind patients. It's very nice if you can to do both eyes, and I think if you're there long enough, so if you have 2 weeks in a particular village and you can get your bilaterally blind people done Monday and Tuesday of the first week, then potentially Wednesday and Thursday of the following week is long enough. I think if you are going to get an infection, and if it follows the rule of 72 hours, which it may or may not do, you should pick it up before you do the second eye. I think in a very remote setting like rural Bolivia, I think you wouldn't do both eyes on the same day, and that's even a topic for discussion in the UK with all the amazing facilities that we have there, and the speed that we can detect issues, and also the understanding from our patients. But so if it's a discussion point in the UK, I think you need to leave a gap between your operations in the settings, certainly where we work. But a week, 8-9 days is probably okay and probably safe to do. The final point that I want to make is that you need to be prepared if you do get an infection intraocularly. You need to have with you vancomycin, you're going to need amikacin. Dexamethasone has been shown to be useful if you can pick up the endophthalmitis in the first 12 to 24 hours, but beyond that it may not have any benefit, and it may actually be detrimental. So, but have it with you. And I would also suggest that you write down the instructions for mixing correctly each of the antibiotics that you're going to inject, because you're going to need to draw up from a vial that is far, far too big, and you're going to need to mix that. And in the heat of the moment, you don't want to make a mathematical error and put the wrong dose into the eye. So John Sandford Smith and Will Dean have written an excellent book on cataract surgery in hot countries, and there are some excellent instructions in that book, which I will put on screen in a moment so that you can copy them, and I'll also put them in the in the bio thing at the bottom, so you can actually copy those down and then have them with you, and it just makes it a lot less panicky. Is panicky a word? Maybe. It's just less stressful if you are following instructions that are proven, rather than trying to calculate on your own what is the actual dose and how much to draw up from each different syringe. It's not terribly difficult, but it just avoids error. So that's my take. You can do cataract surgery safely in a remote setting. When we first started in Bolivia, we had 3 cases of endophthalmitis in the first 3 years. That was about 1%, so that's high. And since we started using Apricam, which we get from Thea, we have had 0 cases, but it also ties in just with this complete review of what we were doing, of the cleanliness of the instruments that we use, the quality of the sterilization, and the taking charge of that step, making sure that we know that what we have on our operating table is clean and that we can safely use it. Taking charge of that, and then the Apricam and the Dex at the end of every operation has thankfully meant that the last 1,000 operations that we have done in Bolivia have been without any infection, and we follow up not just for the first week, but I go back a month later and sometimes 3 months later to follow up, and I see every single patient that we operate on, so I'm confident in what I'm reporting. So that's it. I hope you've enjoyed this episode of Beyond 2020. Please like, it really helps us if you can like the video, and if you can subscribe as well. There's plenty more that we want to share with you of the experiences that we've learned over the coming up to 12 years that we've been operating in northern Bolivia. So thank you, and we'll see you on the next one.